Assalamualaikum and welcome. My name is Muhammad Helmi bin Abdul Halim, and today I will be presenting a case study on a critical topic for any modern organization: optimizing ergonomic strategy for a healthier and more productive workplace. But we are not going to talk about a generic office. Instead, we will dive into one of the most physically and mentally demanding work environment in this world. This is the emergency department. What we learn here about protecting our frontliner healthcare workers has powerful lesson for us all. Here we go about the agenda. Can we dive on in a case study that I will start with it. So we will start by understanding but why ergonomic is a life or that matter in healthcare. We will then examine the specific crisis facing in emergency department through a real world case study. I will walk you through a proven three-pillar intervention strategy, how it was implemented, and most importantly, the measurement of outcome is delivered. We will finish with the actionable recommendation and you can apply it, okay? Why focus on the emergency department? Imagine a workplace that operates 24 hours under blinding fluorescent light, filled with the sound of the machine, ventilator, and the human distress. Staff are constantly in the motion lifting patients, bending over the bed, making a split-second decision under immense pressure. This is not just to comfort it's about a safety. The ergonomic design of this piece directly impact clinical ability to save a life and their own risk of a career ending the injury. So why emergency department that I chose it, okay? The problem, the data is alarming. In the recent study shows that 76% of emergency department staff suffer from a work-related back pain. So about a 40% of higher of musculoskeletal disease rate than a general staff. How about the burns rate is exceeding of 60% in higher volume in emergency department. So it may lead for the patient safety issues. This patient safety in the implication when the error rate in increasing with 80% during a 12-hour shift, a fatigue related medication errors, and the longer patient wait time during a staff shortage. Okay. Now we can the overview of the case study. In the General Hospital of Tuanku Fauzia Police, that are setting in an emergency department, the beds unit in emergency including yellow zone, red zone, and observation zone, and the green zone is about 50 bed emergency in emergency department, as not including extension bed and the wheelchairs. In of the staff, the total of staff in emergency department is 72 clinical staff, is including a physician, doctors, paramedics, and nurses. So how the pre-intervention baseline in that I catch in emergency department hospital Tuanku Fauzia. This about 32 staff have developed of a musculoskeletal disorder. There's a claim they are having a back pain, they have any knee pain, and they have any some of foot pain. So is it ever it mean there are a lot of musculoskeletal disease related with it. So how about the average patient waiting time? It's about a 4 to 6 hours that a patient will waiting in the green zone. Okay, so how about the staff satisfaction? Is make a 2.8 over a 5 on ergonomic system. So what is in the staff crisis? the staff will have a develop of burnout because they have a staff shortage. They need to do a lot of overtime. They have do a lot of 12 hours shift per day. It's about every day, so there's a get a burnout about it. So the staff in the under salary will lead to will lead in from a staff shortage about it. So and the third is a musculoskeletal pain, and the fourth is near miss event as a medication error, needle stick injury. So how about the patient implication? So they will make a daily early intervention of the patient, and the waiting time to see a doctor will be increasing. They are become for impatient, and how is come a patient for during a transportation. Let's go for the strategy one is a physical environment that have in a physical redesign. Their transformation began with the physical environment, the most visible pillars. They tackle the number one injury risk a patient handling. They install ceiling-mounted lift in every trauma bay and invested in power stretchers that required 25% less force to move. So they replace a static workstation with a sit and stand charting station. Place the right at the backside to minimize frantic walking. So they even address the sensory overload, installing a anti-fatigue flooring and acoustic panel that broke the noise level from a deafening 85 decibel down to a manageable 65 decibels. This was not about buying fancy gadgets, it was about removing the fundamental physical barriers to safe care. So in this thing, we dedicate for the ergo break zone with a stretching guidance. The strategy 2 is a cognitive and workflow ergonomic. First is a digital transformation, which is in the emergency department. The resus area need a voice activated alert in the trauma and resus area. Why? Because it is for comfort and for hand free for this our side. In a paramedic, we need to do a documenting, a vital sign, and a medication given. And a centralized monitoring with adjustable displays can give a more good to us because they are centralized and monitored in a one place. So in the second is a cognitive load management. Is it a color-coded urgency system for alerts? Is it with standardized medication dispensing location? The third strategy is human factor and behavioral change. First is safe patient handling program. The mandatory is no manual leave policy because it will increase the patient fall. The second is a team leave protocol when the equipment is unavailable. The third is a real-time biomechanical feedback using a wearable sensor. So the culture transformation in the ergo champion for each shift, and the leadership rounding focus on the ergonomic. What's the outcome can we take? The first is the staff health and safety. It will reduce in a musculoskeletal disease rate in our healthcare provider, and it will decrease in the loss of work days. The staff certification and ergonomic will rise by day. So the second is the operational excellence. The patient waiting time will less than before. It's about 4 to 6 hours before. It will become 3 to the less than from the 3 hours. So what the third is a quality and safety. So the medication error will reduce by the patient. The healthcare get a lot of rest and a lot of the thinking. The patient, and the second is a patient fall during transfer will decrease because the safety of the quality in transporting the patient is more effective. What the recommendation for the health case setting? First is start with assessment emergency department specific for the risk mapping. The second is prioritize patient handling in the highest injury risk area. The third is engage frontliner staff. They know the problem and the solution. The fourth is measure holistically the staff health, patient safety, and the operational metrics. The last is a think system where the ergonomic as integral to quality, not separate initiative. So what can we learn in the first start with a T assessment of our high risk tasks? Engage the frontliner staff as a co-designer and remember in the high-stake environments like the emergency department or indeed any workplace, ergonomic is not a luxury. It's a foundational element of safety, quality, and humanity. The cause of an infection is simply too high. So the emergency department are ground zero for ergonomic intervention. It means investment in ergonomic equal to investment in staff retention, patient safety, and financial sustainability. The cost of inaction exceeds the investment in solution.